let's take a look a little bit more, if we can parse some of this out. If we have to use the evidence we've got, and we want to establish a potential role for disease-modifying therapy in either mild to moderate or moderate to severe disease, how do you do that with these new agents? Which agent goes which way? How do you make these decisions?
I think we have to identify these moderate to severe and patients, and then begin to parse those out and treat those patients.
So if I were to give you, and give you Mirabile D2, just this is it. I'm going to tell you, without right now giving you the criteria for this, I'm just going to say this patient, patient A, is mild to moderate, okay? Of these new therapies, which of these two would be more applicable to mild to moderate as opposed to severe? Would it be the ointment? Or would
No,
it be
because
the injection?
that was mild to moderate.
Yeah, I said, did I misspeak? Mild
to moderate.
Okay.
Yeah, dupilumab is moderate to severe.
Okay,
so that would be the one. And I think, though, it all evolves around education. So as the doctor told us, you know, the patients first start with the creams, keeping the skin moist. And then we go to topical steroids, and it's on and off of steroids. So to your point about step therapy through some of the previous treatments, that, in my mind, establishes the moderate to severe.
Okay.
That's how you begin to identify those.
Okay,
and I totally agree. I think that that's really, you know, a very good way of finding the right patients here is if they just aren't getting by, you know, if they can't get relief from their symptoms and from the disorder, you know, by what's being done now, then they're clearly a good candidate for something more. And then the question is, are they that far off from, you know, from the patients who were studied in the trial? Well, they probably shouldn't be, you know, unless they have some major comorbidity that we really have to sit down and think about in terms of safety. And this is no longer a monetary problem. At that point, this is a problem of risk-benefit for that individual patient and something the patient and the physician have to work out, you know. But if, in the absence of that, then you know, a really good marker for patients having more severe disease is just not responding to current therapy.
Right.
So is it fair to say, let me see if I heard you correctly. I'm going to come back to you for a moment to try to parse this out a little bit more, but somebody with mild to moderate who needs to move to something else, mild to moderate now, would that be someone that you would move first to the topical therapy, and then moderate to severe, then you might move on to dupilumab and the injectable therapy? Would that be how you'd think about it?
That's an interesting concept. I'm not so
Why
sure.
am I not getting...
I think it's really, and I sit here as the representative of the specialty pharmacy, I really think that it's up to the doctor who's been treating that patient.
So the
right?
ratcheting sound you hear is me turning this way.
This way to the doctor. The
and
doctor
he's cringing.
knows.
Does that make sense? I mean,
yes and no. I mean, you know, there are moderate to severe patients who will respond to topical steroids. And if you catch it early enough and you treat aggressively enough, if they do well, then I think we would all agree, why would we put them on a systemic agent, expose them to any of that risk? Even if there's a better risk profile for the newer drugs, it's still some risk that we don't want. So I think, you know, for the mild patients, you know, and you're just getting to your issue of how do you define some of these. You know, as dermatologists, we just kind of know. I mean, like what a mild patient. You just look, you're like, all right, we could get by with a topical agent.
It's the Supreme Court definition of obscenity here, but let's not go
This
there.
is like the worst thing for a payer to hear. It's just like, but you know, when you look at the mild patient, you say, okay, this is a patient who would probably do quite well with topical agents. And we would start with something, you know, a topical steroid, or if they're contraindicated, or if we had access to it, something like these new PDE4 inhibitors. And for the most part, those patients will do quite well in the topicals. When you see you know, some patients walk in and they're just so extensive. The lesions themselves are so severe. You know, we'll start with a topical steroid, but even at this juncture, where we have limited options, I will have a conversation with a patient at that point saying, we'll start with a 3-week trial of topical steroids, and we'll give it a solid effort. But just, you know, I want you to know the options, because probably a month from now, we're going to be starting a systemic agent when these fail. Okay. So you just have that sense.
And see, that's where we're going to want a discussion. It's about that severe patient who hasn't tried something else, and where does this fit? Which I'm not sure how big of a patient population that is. You might have a better sense for how many patients are not self-treating or haven't used generics. Because I think a lot of this will be a moot point. Because, you know, we'll cover these drugs because they're better. The question is, who is the patient? And if it's to set up where you try topical generic TCIs or generic steroids, they'll be in their history. So a lot of this is going to be a moot point. The issue is those patients who haven't tried those other things.
Right. I mean, I don't think anyone's going to, I don't know any provider that's going to want to jump to a biologic agent prior to using even super potent topical steroids, but certainly mid-potency topical steroids.
So if I heard you correctly, and I think this is a major statement, it isn't that you think the drugs aren't good or that they don't work, but the patient population eligible for them needs to be better defined. Is that fair?
That's fair.
Okay.